at the facilities and what we do. And it's a combined event. We obviously talk about what a DEU is, just like Linda brought up. We have that little introduction as to what a DEU is and what's everybody's role. We also develop their abilities with basic safety and quality expectations. I teach fundamentals for the first semester juniors, and that's one of the first things that I do is talk about safety and quality and how you treat patients with dignity and that sort of thing. With the nurses, we also do a think out loud activity, which I'll talk about, a critical thinking activity to help the nurses, the DEU nurses, know how to make a student critically think, because like Michele mentioned, you know, there'll be a really good nurse who's just constantly saying what she's doing instead of asking the student, why am I doing this? Or what do you think I should be doing? Or can you prioritize? We just got report on these 5 patients. Who should we go see first? You know, instead of saying all the time. I mean, first semester juniors, of course, you know, a little different. And we do separate that out. What would I do with a first semester junior as opposed to a last semester senior? We have a providing feedback activity that Michele does a really good job with. As you mentioned, they don't want to get the student in trouble. You know, they don't want to talk badly about the student to the faculty because they're afraid, you know, the student's going to lose trust in them. But you have to understand this student may be taking care of you someday, you know, so we really have to be honest. And these students need to take feedback, constructive feedback, and they have to know how to change their performance so that they are competent and safe. You know, we have to, we really emphasize that with the nurses that come to our orientation. In the last year or so, in conjunction with the nursing process, we didn't develop, but we have another model that we're using, Alfaro Lefebvre's model, and her text that I'm using. It's called Predict, Prevent, Manage, and Promote. Okay, so it's in conjunction with the nursing process. This is more intense than just monitoring a patient. This is actually having your patient surveillance of the patient. Linda mentioned about the failure to rescue issues. You know, and that's the whole idea that, you know, are we really preparing these nurses to think in a complex way, to have clinical judgment? And I bring this to the juniors, their very first class when we talk about the nursing process. And of course, they have no idea what I'm talking about, but I just keep reinforcing it and reinforce it in lab. What is the worst thing that can happen to your patient with pneumonia? I ask the juniors that, and they're just looking at me, oh, they get a fever? Okay, what if they get a fever, then what? You know, so with the nurses at the bedside, I want them to understand this is how we're teaching, and these are the questions you should be asking. Predict, you know, what is the worst thing that can happen? Now prevent. What complications can I prevent? What complications should I be looking for? You know, and then manage. If the complications do come up, how am I going to manage these complications? And then promote. You want to get the patient to their highest level of independence. You know, you want to make the patient push themselves a little bit in certain instances and promote good health. So I bring this up, you know, and we're doing this now. Linda teaches the seniors in the fall, and she gave the same spiel to the seniors in their med-surg course. So these are the basic expectations of students from day one in the School of Nursing. So I want the nurses at the bedside to understand this is what we expect from our students. We expect every patient to be treated with dignity. We expect you to knock on the door before entering, to introduce yourself, of course check those 2 patient identifiers, and to ask the patient how they like to be referred to. I tell them about Don Berwick, Dr. Don Berwick in the IHI. He was the CEO and president of IHI. He was also involved in CMS. And he said, it doesn't scare me to be in a hospital, and I don't fear a medical error. I fear losing myself, losing my dignity. I fear some young nurse calling me Donald when I don't want to be called Donald. I want to be called Don or Dr. Berwick, you know. So I bring that up to them, to the nurse at the bedside. We simulate that in lab. So every skill that the students have to do, like med administration and lab, they have to role play. Knocking on the door, you know, introducing themselves so they get used to it. Safety check before leaving the room. Again, you know, how important is that? I tell the students before you leave the room, stop, make sure the call light's within reach. Make sure the bed's in low position. From, you know, we just keep reinforcing this. And this is what I want the nurses at the bedside to make sure that our students are doing this. Hand washing, strict adherence to infection protocols, of course. People are still dying of healthcare associated infections by the thousands. We're still not washing our hands. Some hospitals are actually giving nurses bonuses on units where they can get the hand washing compliance up to 60%. That's how bad it is, okay? So I scare the heck out of the juniors about infections and resistance and multi-drug resistant organisms and all this sort of thing, and tell them they're supposed to be washing their hands this way, you know, and all that. And then they go to the hospital. They see people not putting on their PPE and walking into a contact isolation room. You know, they see doctors sitting on a patient's bed that has C. diff. You know, I mean, they're just, oh my God, Dr. Fabry, what are we supposed to do? I said, well, you need to be the role models. You need to be the ones that are going to change this, because we're all going to die. There's going to be a bacteria that's going to come out. We're not going to have the antibiotic for it. We're all going to die. So I said, you need to be stewards of antibiotics too. You know, so I really scare them. Fall prevention, still a huge problem. 700,000 falls is the last number that I saw in a year. What is the protocol for patients that are high risk for fall? I teach them the Morse scale, you know, how to do that, of course, the Braden scale. Awareness of look-alike, sound-alike drugs and high alert drugs, okay? I teach them the tall man lettering. This is first semester juniors. This is what you're gonna see on the Pyxis. Hydromorphone, morphine, that sort of thing. Dobutamine, you know, that sort of thing. So they know about high alert drugs. Insulin, 2 RN check with insulin, and a real RN check, not an informal, okay, yeah, it looks good. And I tell the students, that's what you're gonna see. They're just gonna scan their badge, and they're not gonna really look to see if that's the right insulin. And that's when errors happen. So I tell the bedside nurses that. Tubing and catheter misconnections, crazy things that happen. Dynamaps being hooked up to an IV, you know, things like that. So really have to make sure you do catheter reconciliation, like medication reconciliation. Make sure that the tubes are going to the right machines. VTE prophylaxis. 70% of hospital-acquired VTEs are preventable. But we have all these things in place to make sure that the patients aren't getting the VTEs. And why are they still occurring? And it also can happen 5 to 10 days after getting out of the hospital, as you all know. So how important it is for those SCDs to be laying on the floor, or should they be on the patient's legs? So I teach them that. Answer all call lights, the no pass zone. One of the reasons why patients fall is because they put their light on and they see people walking back and forth in front of their room, and nobody's paying attention to the light, so they think their light's not working. And that's when they get up, and that's one of the ways that they fall. So even first semester juniors, even though they're scared, I say go in pairs, answer the light, tell the person that you're going to get them help. Obviously, you're not going to get anybody out of bed without blah, blah, blah. But, you know, don't ignore the lights. Find out what's going on. And a fundamental, non-negotiable respect for everyone, every day, with every interaction. It always made me feel good when the cafeteria ladies would tell me, your UB students are so respectful. That always made me feel good. So, you know, it's teamwork out there. It's collaboration. It's not just one person saving a patient's life. And we have to understand that this is interdependence. We all need each other. We all should be on the same playing field. And I'd like to hear that Karen said she has the physicians getting involved at ECMC with what a DEU is. I don't think we do a good job with that now that she says that maybe we do need. One thing they did at St. Joe's, they had interdisciplinary meetings, you know, with the social work and all that, and the students would go in and present. And that was a really good experience for the students to do that. And there would be a physician there, and usually physicians are pretty nice, you know, they might ask a kind of difficult question, but I think it's important to get our physicians on board, our NPs, our hospitalists, to understand what we're doing here. Thinking out loud, this is something that nurses have to kind of relearn to do. The students cannot see the nurses thinking. The nurse has to be able to verbalize why he or she is doing what they're doing, so the student can understand that. So you can use the think out loud activity for the clinical instructors, for the bedside nurses, or you can do it for the students. So, well, we give them a little example. You have 2 IV antibiotics to hang. One of them is in 150 milliliters of diluent. The other one is 100 milliliters. They're both due at 9 o'clock. Explain to the student how you're going to figure that out. What are you going to do? That sort of thing. So while they're doing whatever activity they're doing, they're explaining this ingrains in the student's head. This is why she's doing that. This is why we're hanging that one first. That sort of thing. It's not natural behavior for these very seasoned nurses, so you really have to get them to practice. So we put them in groups. We had a very big group the last time. We had them in groups of like 4 or 5, and then one person would be the CI, the other person would be the student, and they would think out loud to each other. You know, and it was like, you know, how do you make a peanut butter sandwich? Start from the beginning. So it's a good exercise. You can also use this for the students. What we do recommend to the DEU nurses is not to have the students do this in front of the patient. To use this more like a reflection after the fact. So tell me why you did what you did, you know, that sort of thing. So it helps the student kind of think through the whole thing of making logical decisions based on facts or things that they've seen. And serious action needs to be based on logical processes. So this helps stimulate the student thinking. Models. This is a conceptual model of critical thinking. The National Council of the State Board of Nursing had this model in effect for basing on their NCLEX boards, on their nursing boards, how a new nurse, a novice nurse should think. This is what they should be able to do when they get out of nursing school. Recognize cues. Well, that's like assessment, right? Generate a hypothesis, diagnosis, nursing diagnosis. We're trying to get away from nursing diagnosis. We call it patient problems now. Judge the hypothesis, plan, take action, implement, and then evaluate. So essentially, this was the nursing process. So the National Council heard a lot of things coming out of these new novice nurses. A lot of the novice nurses were involved in medical errors, and a lot of it was due to poor clinical judgment. They were hearing from hospital administrators. They're not happy. These students are passing their boards, but they don't know how to think. They still can't think like a nurse. So what good is it having these boards if they come out, they pass, they still aren't doing a good job. They're still making errors. So they put a strategic planning committee together, and they came up with a new model. And they're hoping someday to base the NCLEX, the next gen. Everybody heard about the next generation? They're saying now 2023, and they're going to base it on this model. So believe it or not, I show this model to the juniors, okay? So we're incorporating this model into our education, all right? So, and I want bedside nurses to understand this model too. And when I look at models, my eyes glaze over, you know, so I have to put, I put an actual situation. So the nurse has to recognize cues. They have to know what is relevant and what isn't relevant. So they walk into a patient's room. They had been taking care of the patient all morning. Now the patient is very anxious, and the patient is diaphoretic, and the patient just looks like they're in a lot of distress, okay? What am I gonna do with that? How do I analyze that, okay? Oh, and I just want to tell you, this is in your packets too, in the little write-up. So what am I gonna do with that information? Form a hypothesis. That's a fancy way of saying, what's an explanation for this evidence that you just discovered? What are you going to do with that? What's the hypothesis? Then they're going to refine it and start to prioritize. So my patient's post-op, he could be in pain, but he also has a history of a pulmonary disease, COPD. So I remember that maybe he could be hypoxic because that affects your level of consciousness. So you're going to refine that. Patient says that they're not in pain. Okay, it must be hypoxia. So now I'm going to generate some solutions by gathering some vital signs. I do a pulse ox, it's 88%. I need to take action. I remember if I should check to make sure that flow meter and the oxygen tubing are attached because he just came back from chest x-ray. Okay, so that sort of thing to really, and when we do a story like this every class, we have Vivian Brody is the name of the patient that we have all through junior year, and it actually goes next junior year, and put the students through this so we see, we're teaching the students how to apply thinking, but we really need to teach the students how to actually think, you know, like a nurse. We're kind of like skipping that step, and if we keep ingraining this into them, then maybe they will stop and start thinking like this. So they're hoping that this is going to improve these failure to rescue rates that we keep hearing about, that there's going to be less medical errors that we keep hearing about. I'm interested, we saw some examples of the 2023 NCLEX is really major, like some of you have seen it. They can't figure out how to score it. That's one of the issues that they're having. You know, so this is the clinical judgment model that now the NCLEX is going to be based on, and we're incorporating this into our curriculum. And I show this to the staff nurses. So that leads me into the critical thinking scenarios. So now we have about 8 different scenarios. We put the nurses into groups. We have 4 case studies. It's a team-based activity. So the DEU nurse and the student are caring for a 78-year-old female that has a heart failure exacerbation. The patient's on O2. The patient has to be assessed as a fall risk. There's a bright yellow blanket on the foot of her bed. After receiving bedside report, the nurse and student are entering the patient's room to do a morning assessment. It's the student's first clinical rotation as a junior. What can the CI do to promote this nursing student's ability to think like a nurse? So these are some suggestions. We don't have these on the handouts right away, but then I review them, okay? So the nurses have to come up with ways. How can I get the student to think? First semester junior, never been in a hospital. What can I do here? What kind of assessment? So they had some health assessment. We're gonna tell them that these are new. This is how far they've been in health assessment. They haven't even auscultated lung sound yet, you know, so what can we do here? But they should have a general idea of what priority assessments would they need. What type of data do we have to collect with this patient? What equipment should they have on? We talk about SCDs, that sort of thing, O2. And what do we need to keep these patients safe? We can ask, what is the patient at risk for? You know, think about it. In your heart failure, what could happen? Could the patient, you know, we talk about fluid and electrolytes, we talk about hypervolemia when they're juniors. They should be able to start taking this stuff out of the classroom and putting it at the bedside, okay? They have to bring that stuff, and sometimes they don't. But if we ask the right questions and keep prompting them to start thinking, you know, might help. What are some signs and symptoms that they're deteriorating? So now we had the same scenario with the same group, and we say, now you have a senior. It's their last semester of nursing school. So now what are you going to ask them? Now, why is this patient still in the hospital? That's important to know. We don't want the patients in the hospital for long periods of time because they're going to get something, right? Plus it costs the hospitals a lot of money if there's not efficient care. What is the underlying pathophysiology of the problem? What are the priority assessments? What's the worst thing that could happen to this patient? And what nursing assessment would help detect these complications? Again, that predict model, predict, prevent. What was the relevant data you received from report? You know, I think it's important for the first semester juniors, I tell the nurses, when they hear report, it's like a different language that first time, because there's a 20 angio on the left AC and, you know, that sort of thing. The students are like, what? You know, so, but these seniors, they should be getting it. They should be taking a full report on day one from what the nurses are saying. What's the intended disposition for this patient? Are we getting this patient ready to go home? They need to start thinking this, you know, they need to be, you know, on top about getting this patient out of the hospital to the right level of care in this level. What goals does this patient need to be reached to get discharged? Is this patient going home on O2? If so, did they have home O2? You know, think of these things. What can we do to improve the self-management of this patient's care? All these patients come in with tons of chronic conditions, right? Nobody has one disease process. Everybody's got 4 or 5 comorbidities. So these seniors need to know that, and they need to know what to look for and how to make sure to discharge that patient safely. And what new orders are we anticipating? And that's something I told the nurses. some of the new, I talked to a lot of the new grads, you know, after they take their first jobs, they said one thing I wish we would have done more in clinical was take note of the physician orders. It was like the nurse would tell them what the orders were, but it was, the seniors weren't told, you know, what orders to anticipate or to look for orders. So that's something I told this last batch of the DEU nurses to think about that. And that's where these great notebooks come in, because it's a whole different level. You know, you got to get out there and tell them this is totally different. Yeah. HIPAA, anything educational is okay. You know, I had a doctor in the interdisciplinary meeting say, well, these students shouldn't be hearing all this information. Yeah, they can. It's educational, you know, and they know that they're not supposed to put this on Facebook and they're not supposed to talk about it. They get the whole HIPAA, you know, thing. So it's too bad. I hope they change that rule.
Yeah, another thing I want to say about that too is all of our students do the agency orientation for all these different agencies, and they sign an agreement that says they will abide by HIPAA. So if that's something that's not in place at with your clinical partners, it's probably something that should be. Okay, looking at feedback. When we do our DEU orientation, we do an exercise on giving feedback. And this is, you know, similar, I tell all of the CIs, this is similar to what we do as a nursing process, right? It just keeps looping around. So we look at discovering issues. You know, is it self-discovery? Is this something that the student said, oh gosh, I didn't do a very good job on that, or I want to get better on that? Or is it something the student did that they didn't even notice that they might be able to improve on it? And then it's assisted discovery. But again, the CI needs to not say, oh, you did a horrible job at that. They need to say, how do you think you did on that? You know, what went well? What could you do better on? So, and then they need to look at whatever it was, analyzing the causes and consequences of why it needs to improve. Looking at creating options and solutions for improvement. So could we, you know, the CI and the student working on this together? How could you do this better? What can you do to improve on that? The commitment to action by both the student and the CI. The CI saying, I'm going to find opportunities for you to work on that some more, or with our next patient, we'll work on that some more. And the student, you know, committing to, yes, I need to improve on that. Or the student saying to the CI, could I, you know, have some more opportunities? Maybe the CI will put them or find another patient on the floor. And that's where your clinical faculty comes in too, because the clinical faculty can work with that student to give them more assistance in whatever they need to work on, and maybe find some other patients on the floor. I mean, sometimes we'll go on, I still say floor, I know I'm old school nursing, I'm sorry, units. The students will, the clinical faculty will be on the unit and they'll say, you know, we need students to get practice in this. Can we do some blood draws today? Can we do some IV starts? So those are things that the clinical faculty can help with too, to take the student and do different things to help them improve. And then evaluating that performance. Is it going better? Did they do it correctly? Are there some other things they need to work on? Just that constant feedback cycle. One thing we really like to do and teach our CIs too is the sandwich model. That's positive, improve, positive. So letting them know what they did a really good job on, and letting them then know what they need to improve on, and asking them to, something you think you could have worked on better in there, and using this model to come up with their plan, and then saying, you know, I think if we do this and implement this plan, you're going to do a great job on it. So after we do it a few more times, let's go back to this. Let's see how we're doing on it. And that's that commitment to action, to just keep working on it. You know, as somebody said earlier, quality improvement never ends. It just is a continuous cycle. We have feedback scenarios that we give out, and we put the CIs when they come in for orientation in groups, and we look at these, and they have to go through them and look at them for the constructive purpose of the feedback, what they're observing, reactions, consequences of the student's behavior. So again, one CI will play the CR, two will play the CI role. We'll have one, put themselves in the student's spot, giving the student opportunity to respond, specific suggestions that the CIs have versus and some suggestions the student may have, and then summarizing and expressing their support. Here's one of our example scenarios. So we have a student nurse giving medication administration of nystatin, swish and swallow. It's ordered orally, and the student prepares the med and then says, oh, I'm going to go put it on the patient's open diabetic leg ulcer because they state it's an antifungal for their infected leg wound. So we kind of call this section of our giving feedback the good, bad, and the ugly, and I didn't name it. It was actually the person that did the presentation before me had named it that, but I thought, why not? Let's just keep it that. So I kind of asked the CIs, what do you see this one? Is it good, bad, or ugly? I'm hoping they're saying bad, maybe ugly, could be ugly. And then we go through this about how they would handle it and how they would approach the student. And that goes back to, again, you need to have something set up with the student so the student knows when they need to stop or you take over to prevent an error. Another one we have is preparing IV Solumedrol and subcutaneous insulin for a patient. Another nurse interrupts the preceptor to ask about a different patient. And, this is just a wonderful example about how you should have that red flag zone when you're passing meds. Shouldn't be any interruptions. Student's about to administer the IV methylprednisolone, and the preceptor turns her attention back to students and notices that the blunt needle attachment is in the insulin vial and not in the Solumedrol vial. So ask the preceptor, what do they do? So they talk about their reaction, the sandwiching effect, telling student, try to find a positive in there that you could say to them, okay, you used a blunt needle to draw this up. However, that's not what we use to draw up insulin. And that's not what you're supposed to be drawing up. So giving them some constructive feedback, what happened here, what didn't you know, and figuring out what didn't they know. Did they forget that they, couldn't draw up insulin with any needle but an insulin needle? And why were they drawing up the insulin when it was a different medication? And working with the clinical faculty too to let them know what happened here. So, when something like this happens, the faculty needs feedback on that because, we watch our students too. We want to make sure that they don't have patterns of behavior that are going to lead them to be an unsafe practitioner down the road. So giving the student opportunity to respond, reflecting on their actions, and then what are the next steps? How do we go for a plan of improvement, working with the clinical faculty, and maybe bringing the student back to the lab to redo a med pass or two in the lab. Again, making it a positive process, and then again, the CIs feel bad. They want to be that friend, that support for that student. And it's hard sometimes when these issues do come up, as positive as they can make it, reinforcing to them, it's not getting the student in trouble. It's putting that student out there as your, eventual coworker, as somebody you would want taking care of your patients and possibly taking care of you, why they're doing it, what's the purpose, making it regular. Even if things don't go wrong, the students need feedback every day. We tell the CIs, you did great on this today. How do you feel you did on things? Is there something you want to work on tomorrow? Okay, we'll find opportunities for that. So really making that feedback, it's got to go on constantly. You did a good job in that. Keep it up. What are we going to work on next? But when it is something that needs improvement, it's got to be specific and there's got to be follow-up.
Okay, and lastly, I just want to discuss the evidence-based practice that we also obviously focus on and research that we do on the nursing units. We always want to do our project on something that's going to help the nursing unit, the specific unit, help the nurses practice. help the patient and patient's care, something that means something. We don't want to do some study that everybody does, you know, that sort of thing. So we really want to do something specific. What improvements are needed? Are you analyzing 2 products? Do you need us to do something with that? So for the one course, which is the clinical course that I coordinate, they have to form a PICO question, okay, about whatever the subject is. And then they come up with, they have to find the evidence. They have to use so many scholarly journals, find the evidence. They make a poster board for the nursing unit, a pamphlet. I had students, we had readmission rates of heart failure was a big problem with one of the nursing units. They came up with this great pamphlet that they actually used for a little while for the patients and that sort of thing. So it doesn't necessarily have to be a poster. And then for my leadership course, I teach a course, coordinate a course called Transitioning from Nursing Student to Nursing Leader. They have to do a public service announcement about this subject. 3 to 5 minutes, who's your audience, what do you want to get across? They have to be persuasive and relevant call to action. The more creative, the better. We had so much fun with this. So this is just one I was going to show. Oops.
Hi, I'm Targeter, and I'm here to talk to you about chlorhexidine gluconate, or CHG for short, impregnated dressings and their effects on preventing central line-associated bloodstream infections, also known as CLABSI, in healthcare. We are always looking for ways to prevent infections and further complications in our patients. A lot of times, patients with central lines are receiving medical treatment that depletes their white blood cell count, causing them to be neutropenic and thus at a higher risk for infection. Teens in the need report that infection-related to central lines are a serious cause of morbidity and place a heavy burden on healthcare resources. CHG impregnated dressings are semi-permeable, transparent dressings with a gel pad containing chlorhexidine gluconate 2%, an antiseptic solution used to reduce bacteria on the skin. This multi-purpose dressing not only secures and covers the central line, but it allows chlorhexidine to be continuously present at the site, making an attempt to decrease infection rates. Timsit et al. Report a decrease of CLABSI by 60% with the use of CHG impregnated dressings when compared to other alternatives, like a biopatch dressing. Biopatch dressings, alternatively, require additional sterile dressings to cover the site while it is placed around the catheter at the site of insertion, unlike the CHG impregnated dressings, which are one-stop application dressings. The extra step taken to cover the patch is another opportunity to introduce bacteria into the catheter insertion site. The application of the biopatch dressing is often more complicated and done incorrectly. This tends to be a result of poor labeling of some of the discs, which leads to confusion about which side goes on the insertion site and which side faces up. Other discs are properly labeled, indicating proper application. In addition, not all materials required for this dressing change are included in the kit. All materials, however, are included in the CHG dressing kit, and the dressing itself is one piece, ridding of any confusion goes on how to apply it to the site. When you look closely at the catheter insertion site covered by a CHG dressing, and compare it to the site covered by a biopatch disc, what do you notice? The insertion site is visible underneath the transparent CHG dressing but covered by the biopatch disc. The biopatch disc doesn't allow for proper assessment of the catheter insertion site to detect signs of infection. Another point for the CHG dressing. Not only are CHG dressings more efficient at decreasing CLABSI, but they are cost-effective and extremely valuable. Infection rate reduction, longer intervals between dressing changes, and the CHG dressing's ability to absorb drainage and bleeding save the hospital and the patient both time and money. What questions do you have? Talk to your nurse about a CHG dressing today to better protect yourself from developing a CLABSI. And remember, one CHG patch every 7 days proves to keep the CLABSIs away.
So that was just their project that they did.